Okay, we're back from the break, and again, thank you for tuning in, Pahrump. I'm Dr. Michael Reiner, and we have Barbara Cutolo, right? Yeah, she's one of my hospice nurses that works with me, and we're talking about a very difficult subject, which is the end of life, and what can one of the services that we provide, and I work with, and I'm a medical director for Comfort Hospice, and just talking a little bit about what hospice does and how it exists and why it's such a useful function. Right. Not everybody, again, likes hospice or thinks of the word. And you said a very good point on break, which was hospice is not just for cancer patients. Hospice is for anybody that has any particular illness that could possibly in their life in the next 6 months. It could be a stroke, it could be a heart attack with congestive heart failure, it could be a lung condition, it could be Parkinson's, it could be any of those unfortunate diseases that are chronic.
Yeah, any chronic.
Yeah, that are chronic. And so at any rate, one of the things that we were talking about was the myth of hospice, and it reminds me of something I talked about, which is not a lot of people remember the movie Psycho. A lot of the younger people don't, but Psycho was one of these movies where Anthony Perkins played Norman at the Bates Motel. Well, it's unfortunate that any role that Anthony Perkins had after that movie, he was associated as Norman from the Bates Motel. He never could shed that first impression.
Right.
And hospice does have that same problem. Because when I've had the opportunity to talk to patients, I mean, the one thing is they think the doctor's given up on me.
Right.
And the doctor is basically relocating me to a room that he's just going to give me morphine and I'm going to die.
Right.
And that's exactly the opposite. That was the old hospice in the 80s because that's all that it really was there for.
Right.
But that has totally changed today. We do have a caller. It is Diana, and it looks like she has a Medicare question. Good evening, Diana.
Seconds.
Hi. I'd like to know, does insurance control Medicare, how things are paid out?
What was that?
Does insurance control Medicare, how it's paid out?
Well, Medicare is its own government program, and Medicare determines what it will pay for services based on a lot of factors, and insurance companies, private insurance companies, set their rates based on what Medicare establishes as a fair rate for that service in that community. I, as a physician, could charge $1 million for your office visit, but if Medicare decides it's only worth $80, well, guess what? I get 80% of the $80, whether I like it or not. But that's if I choose to accept assignment for Medicare, and if I don't accept assignment, then you as a patient might be liable for the difference between what Medicare pays and what it doesn't pay. I don't know if that answers your question, but insurances will usually pay a percentage of what Medicare pays, either 100% of the same allowable rates or some number smaller than that. Does that answer your question?
She's gone.
She's gone. Okay. So, at any rate, okay. Back to the hospice issue, so getting rid of that dilemma or that stigma of being an end-of-life program, and that you're just giving something, and that's true. I mean, the idea is timing the patient. I mean, putting the patient on a little bit early, making sure their needs are met, and then if they aren't, then we like to discharge that patient to home care.
Right.
Right.
Yes.
And so as an RN in home care, you have to have what they call a skilled need.
Skilled need.
Can you explain a little bit about that?
A skilled need it can be anything from giving an injection to education. And education is huge in home care because we want to educate the patient on their disease process, on any medications they might be taking, on how to change a dressing or how to administer their own IV medication if it has to be done like every couple of hours. And so there's a lot of education in home care.
Right.
But it's definitely based on a skilled need.
Right, something that they and also I understand it as a taxing need too. So if they have that skilled need and they can't get, it's taxing for them to get out of the home.
Right, right. They have to be homebound, or it would have to take a lot of effort, a taxing effort, in
Right.
order to get out of the house. Like, you have to get out of the bed and into a wheelchair, and your wife or husband is frail and can't get you into the car. You know, that would be a taxing effort to get you out of the house.
Now, does Medicare place any limits on the length of home care?
No.
Okay.
They have to meet a certification.
At that point, they got sick before they died, so they stopped using the nicotine. And so that's what we're promulgating, and that's why we have such a problem on that. Let's talk a little bit about congestive heart failure. One of those things we see a lot of too.
Yes.
A lot of heart disease out there, a lot of COPDers with heart disease. And so one of the rule of thumb is hospice terminal diagnosis should be a disease that might in their life sooner, but we can and do sometimes adjust which illness, because some people want aggressive therapy.
Right, right,
Some people still want to see their cardiologist.
right.
So if their COPD is likely to kill them, and that's one of the things that, you know, seeking aggressive therapy is one of those beautiful things about hospice, is that if you decide that you have a pulmonary infection, or you decide you have and you want to go to the hospital, or you want to seek aggressive therapy, you can revoke from hospice.
Anytime.
Anytime. It's a light on, light off program.
Right.
Meaning you flip the switch on and you flip the switch off.
Right.
But every time you come back on hospice, there's a qualification period. So if you decide to go seek aggressive therapy and get better, you may not be eligible for hospice again.
Right.
But that's a good thing,
Yeah, it is.
right?
Yep.
That's a good thing.
We get you better.
So do you like doing hospice medicine?
I do. I really do. I don't find it's not like a job,
Right.
because I'm visiting with people. You know, I'm going in and talking with the patients and visiting with them, and so it's not like working.
Right.
You know, I'm not on my feet 12 hours a day, you know, at the bedside. I'm in their home chatting with them, and I can do my assessment by just talking to them. You know, can they talk in a full sentence? Do they get short of breath? You know, and all of that, you know, I can do just having a conversation.
Plus, it's the gratitude that you receive.
Oh.
You know,
Yeah.
when I go and do a house call, or when I see a patient, I mean, they're so grateful for the services, as opposed to
are.
coming into a doctor's office and they wait. I mean, some people wait an hour or 2 hours to see me sometimes, and you know, you just see the steam boiling off their head. You know, it's a lot. It's a lot to come in a doctor's office and wait. There's a lot of fear involved in coming to the doctor's office. You don't know what the doctor's going to say. You don't know what you're up against. But that doesn't exist, you know, when you're coming to the home. You're coming on their turf.
Right.
And so they like that.
Yeah.
Okay, we're going to go to break. And I just want to make a mention again, 727-8750 is the call-in number. We also are putting up the hospice number for Comfort Hospice on the TV. So if you have any questions after this program and you're too shy to call in and ask about that, you know, we're going to put that number up there for you, and we'll be right back. Thank you again for tuning in.